So you've had your basic EKG classes, you've had your basic 12 lead EKG classes. We've done the ABCs, gone over LVH, RVH, bundle branch blocks, all that, all the boring stuff. Here, let's go over the fun stuff, the XYZs of your 12 lead, and let's see what we can pluck out and maybe impress a cardiologist or three. Now we're not just looking to impress our cardiologists and EP doctors, but potentially save some lives and drastically improve patient outcomes. So what we're going to talk about today, a number of things. We're just going to gloss over a lot of these. You can certainly read into any one of these topics ad nauseum, but we're just going to talk about it real quickly. First off, trifascicular blocks. We've talked about bifascicular blocks, right bundle branch blocks with hemiblocks, either posterior or anterior. So we'll talk about trifascicular block, which occur. We'll talk about Brugada's syndrome, a sodium channel syndrome that is, I guess, congenital, familial. We'll talk about our cardiomyopathies, including hypertrophic Takotsubo and arrhythmogenic right ventricular dysplasia or arrhythmogenic right ventricular cardiomyopathy, depending on who you're talking to. I'll also talk about Ebstein's anomaly, which is somewhat rare, but a birth defect, and we'll chat about that real quick. We'll talk about our ventricular tachycardias. VTAC only doesn't come in just one flavor. It comes in a few flavors. We'll talk about right ventricular outflow tachycardia. We'll talk about fascicular ventricular tachycardia. It's VTAC originating from our either posterior or anterior fascicles. We'll talk about bidirectional ventricular tachycardia, which is pretty rare, but it's kind of cool. So we'll talk about it just briefly, and then we'll talk about things that you should be activating the cath lab for when you see Wellens syndrome or De Winter's T waves. These don't have ST segment elevation, but when you see them, you should be activating the cath lab immediately, because if you don't, your patient will die. Just have a bad day. And then lastly, we'll talk about a couple interesting things, not necessarily EKG wise, but things that you might see in the transport community, intra-aortic balloon pumps and their associated waveforms, and talk about that real quick. And then left ventricular assist devices, which you may have a patient in your jurisdiction, in your response area, that has an LVAD, and how to deal with them. Now your trifascicular block, we're just adding another element to our bifascicular block. So if you remember back to your bifascicular blocks, we need a right bundle branch block and either a left anterior hemiblock or a left posterior hemiblock. Now on top of that bifascicular block, we're adding some sort of AV block. So parlance-wise, we're calling it an incomplete trifascicular block. If we've got that bifascicular block and either a first or a second degree AV block, then we're calling it a complete trifascicular block if it's got that bifascicular block and a third degree AV block. This can arise from a number of conditions. They can either have hypertrophies or on the other end of the spectrum be having an acute MI. Again, always treat the patient, not the monitor, but if you see this, this is a trifascicular block. And here, for example, we have an incomplete trifascicular block. We do have a right bundle branch block, which we can see with an upright RS complex. Here we go to our J point, go backwards, and we have our turn signal method. And we have slurred S waves in V6 and lead 1, so we can confirm our right bundle branch block. Then we also have a left axis deviation, upright in lead 1, negative in AVF. And then we have a pathologic left, so up, down, and down in 1, 2, and 3. So we've got pathologic left axis deviation, which tells us we have a left anterior hemiblock, plus we have right bundle branch block, which we just confirmed. So we've got that bifascicular block. If we add on to that, we do have a first degree AV block. We've got that long PR interval right there, and you can measure it in whatever lead you'd like. But so here we've got our incomplete trifascicular block. Moving on to a little bit of some crazier stuff here. We've got Brugada's syndrome, so not to be confused with Brugada's criteria, which is used in VTAC, versus SVT with aberrancy, or Brugada's sign, which is used in VTAC. This is Brugada's syndrome, or the Brugada brothers. They really loved EP studies, so they've come out with a lot of things, named a lot of them after themselves. So our Brugada's syndrome is a sodium channel disorder and is associated with sudden cardiac death. There are three types, and with this, we're looking for signs of it in the leads V1 through V3. In your type 1 Brugada syndrome, you're going to see the ST segment is a little bit elevated, and it's going to be coved, followed by a negative T wave, and you'll see that just in a minute here, but it's this coved, upright coved ST segment with an inverted T wave. Type 2, your ST segment, it's going to be a little bit elevated. It's going to be saddle-backed, almost biphasic, but that biphasic portion never goes below baseline. With type 3, it's just a combination of type 1. Type 2, you might see a little bit ST segment elevation that's coved, and then another lead, V1 through V3, might be that saddleback. Here we see an example of a type 1 Brugada syndrome. We see if you look at V1 through V3, especially V1, V2, we do see those coved ST segments with inverted T waves. So when we say coved ST segment, that's what we're talking about. It's kind of slight ST elevation, and it just kind of bumps up and then inverts with the T wave. As in comparison, this is actually a type 3 Brugada syndrome, but it points out the saddleback ST segment pretty well. You see the V1 is coved, it's got that inverted T wave, but that saddleback in V2, this is what we're really looking for when we talk about that type 2 saddleback. You see the ST segment a little bit elevated, but it's got that saddle looking appearance to it going into the T wave. In order to diagnose Brugada syndrome, we have to have a couple things. We must have some sort of identifiable ECG sign that we just talked about, that type 1, type 2, or type 3, plus one or more of our clinical findings. Brugada syndrome is associated with syncope or near syncope, and then polymorphic VTAC could also have your patient go into VFib, and then also one of those and/ors, a family history of sudden cardiac death. So they had to have an ECG finding on the 12 lead plus one of these clinical findings. Essentially, treatment for Brugada syndrome is implantation of an AICD. Now let's get into our cardiomyopathies. The first one we're going to talk about is a hypertrophic cardiomyopathy. And this is the #1 cause of sudden cardiac death in young athletes. This is not to be confused with commotio cordis, which is when an athlete or anyone really gets hit in the chest and develops an R-on-T syndrome, R-on-T complex, and throws them into a VTAC, VFib. This hypertrophic cardiomyopathy affects about 1 in 500 people, so it's pretty common relative to other syndromes. This is associated with syncope. You will have your patient with exertional symptoms. What you're going to see on the 12 lead, you're definitely going to see left ventricular hypertrophy due to left ventricular outflow tract obstruction in these patients. And this is also caused by left ventricular cellular disarray, which is really just the left ventricular cells aren't arranged the way they should be. And this causes just this aberrant electrical vectors in the left ventricle. Your HCM patient will definitely have left ventricular hypertrophy, and that's just due to the left ventricular outflow tract obstruction. So you'll see your high voltage QRS complexes in the precordial leads and your LVH criteria as normal. If they have septal hypertrophy, just a hypertrophied septal wall in the heart, you'll also see very deep pathologic Q waves, although they'll be narrow. They'll be less than 1 millimeter wide in most cases. You'll see these in the lateral and inferior leads. More common in the lateral than the inferior, but you might see them in the lateral and inferior leads. You might also see large negative deflected T waves in your precordial leads, and this leads us to thinking about an apical hypertrophic cardiomyopathy. So definitely LVH, and then either one or both of the septal hypertrophy or apical cardiomyopathy signs. Treatment for HCM, sodium channel blockers, calcium channel blockers, possibly implantation of an AICD, or in the case of septal hypertrophy, the cardiologist might want to go in and do a septal wall ablation. So let's take a look at a couple of HCM patients. This first one here, you'll see, has both septal and apical involvement with their HCM. So we're seeing in the lateral leads very deep but narrow Q waves. We can also see that in our inferior leads a little bit. With the apical portion, we can see very deep inverted and symmetrical T waves along our precordial leads. In our second patient, we don't have those deep, narrow septal Q waves that we saw in our previous patient. So our lateral leads, no Q waves here. Our inferior leads, no Q waves there. But we've got our inverted symmetrical T waves in our inferior, or excuse me, in our precordial leads. The next type of cardiomyopathy we're going to talk about is Takotsubo cardiomyopathy. This is an apical ballooning of the left ventricle, so there's a very sudden and temporary weakening and stressing of that left ventricular wall, usually triggered by stress. This is what we call the broken heart syndrome. If you've ever heard of that, people actually do die of broken heart. This apical ballooning will usually present as either a sudden onset of CHF symptoms, or your patient may just go straight into cardiac arrest. There are a lot of syndromes in medicine, in cardiology or elsewhere, that are named after the person who discovered it or wrote it up first. But Takotsubo cardiomyopathy is actually named after an octopus pot trap, a Japanese octopus trap named Takotsubo. And basically, they drop this ceramic pot down there. The octopus says, "Hey, look, a free home," and gets in there, and then they pull it up, and they've trapped their octopus. And that's what the left ventricle looks like when you have this cardiomyopathy occurring, this very sudden and temporary cardiomyopathy. So here on the left we see a normal left ventricle, thick muscular wall here. And then when you have the myopathy appear, that muscular wall just weakens and thins, and you have this ballooning. This is that apical ballooning, and it looks like that octopus pot. In Takotsubo, this is one of those STEMI imitators, so it mimics a STEMI. You will see ST elevation on your 12 lead. So please, we are not going to be calling this Takotsubo out in the field. We need to call a code STEMI. We're not going to differentiate out in the ambulance in a 911 setting. But when we bring them to the cath lab, we're not going to find any blockages. The arteries will be clear, and this is due to just a microvascular spasm that's causing this ST elevation. On top of this, you'll see ST elevation while symptoms are occurring, chest pain and other STEMI type symptoms. But after the fact, when symptoms subside, we'll also see it go from ST elevation to a flipped T wave. Here's a Takotsubo patient. This is the same patient. The top 12 lead here is during symptoms, chest pain, and other STEMI type symptoms. We do see ST elevation in multiple leads. Again, microvascular vasospasm is what's going on. And then taken a couple days later, this bottom 12 lead, we see the ST elevation has gone away, and we are left with a T wave inversion. Here's your apical ballooning that we'll see in the cath lab. You'll notice that that left ventricle is ballooning out and taking the shape of that Japanese octopus pot. Our next cardiomyopathy is arrhythmogenic right ventricular dysplasia, or right ventricular cardiomyopathy. They go by both names. Basically, this is you're looking at the right ventricle, and we're replacing muscle tissue, cardiac muscle, with fatty cells. So those fatty cells don't transmit the electrical vectors like they should, like the muscle tissue would. So we're seeing changes on our 12-lead EKG in that respect. This is the number 2 cause of sudden cardiac death in young people. This is after your hypertrophic cardiomyopathies, and this affects approximately 1 in 5,000 people. So again, relatively common. You will come across this from time to time. So here we're looking through a microscope at our right ventricle. Instead of the top, where we should see nicely placed cardiac muscle tissue, on the bottom in our ARVD, we're seeing fatty deposits within the muscle tissue. And again, these aren't going to transmit our electrical impulses the way they should. It's kind of running into a lake, running into a pond, running into a pool. You're up to speed, and then you hit this wave of water, and in this case, it's a wave of fatty deposits, and you're just kind of ripple a little bit. You're going to slow down a little bit until you get back up to speed. In the case of ARVD, we need both clinical and ECG features to diagnose. On the clinical side, we're going to see a family history of sudden cardiac death. We're going to see exertional symptoms, chest pain, shortness of breath, diaphoresis on exertion, and also possible signs of right ventricular failure. On your 12-lead side, we're going to see an epsilon wave, which we'll talk about here in just a moment. You'll see T wave inversion in V1 through V3. You may see a slurred S wave in V1 through V3. And ARVD has a high likelihood of leading to right ventricular outflow tract tachycardia, which we'll talk about a little bit later in this presentation. Your epsilon wave is a hallmark sign of your ARVD. Your epsilon wave is going to be a very small fluctuation in your ST segment, usually seen in leads V1, V2, possibly V3. And it's just a little ripple. So imagine you are running full speed, and then you hit a small pool of water. You're going to slow down a little bit, things are going to ripple, and then once you clear that small pool of water, you're going to get back up to speed. And that's what that epsilon wave is. That's an electrical vector, electrical impulse hitting that fatty deposit, and then clearing the fatty deposit, hitting the muscle tissue once again, and continuing on. So again, best seen in leads V1, V2. We'll talk about lead F1, your Fontaine lead 1. But your epsilon wave combined with an inverted T wave in V1 through V3, somewhere in there, it's really a hallmark sign of your ARVD. Since we mentioned the F1 lead, we can talk about our Fontaine leads very briefly. These are used to isolate the activity in the right ventricle. So again, our right ventricular dysplasia, we're looking at the right ventricle. The epsilon wave is going to be seen most prominently through these Fontaine leads. What we're going to do, we're going to take our white lead, our right arm white lead, place it on the manubrium, take our black lead, put it on the xiphoid process around there, take our red lead, put it in our normal V4 location. This will isolate our right ventricle and activity in the right ventricle. And we go to your monitor, whatever monitor you're using, view it in lead 1, 2, or 3, and these become Fontaine 1, Fontaine 2, and Fontaine 3 leads. So if you're wondering, is that an epsilon wave or not, switch over to this Fontaine lead, and you'll be able to pick it up immaculately. Here we're looking at our normal 12 lead that we take on any patient, but looking at V1 through V3 we notice some abnormalities in that ST segment, especially in V1. We see a little hunk of chunk right there, little hump to bump, just an extra little fluctuation in there, and this is also associated with inverted T waves. You can see in V1, V2, V3 pretty much through most of the precordials, but we definitely see our extra fluctuation in that ST segment. In this next 12 lead, this next patient, again looking V1, we definitely see an extra little fluctuation in that ST segment. It's a little, so that's where the electrical impulse is hitting that fatty deposit, just fluctuating a little bit, rippling a little bit, and then catching the muscle tissue on the other side and continuing on through. And then we have those inverted T waves. Now we're done with our cardiomyopathies for the most part. So let's talk about Ebstein's anomaly. It's a pretty rare birth defect, typically associated with tetralogy of Fallot. But this is definitely a congenital malformation of mostly the tricuspid valve, but deals with the right atrium and the right ventricle. On physical assessment, you're going to hear an S3 heart sound and an S4 heart sound. We've got our normal heart on the left-hand side, our Ebstein's heart on the right-hand side here, and just look at the tricuspid valve here as normal. It's not allowing backflow of blood into the right atrium. Here, because we have that malformed tricuspid valve, it does allow for a little bit of a backflow of blood into the right atrium. And again, you might have this septal defect due to tetralogy of Fallot, since this is a pediatric birth defect. On EKG, you'll see a large P wave, typically a large P wave, indicating right atrial enlargement. You may see a first-degree AV block, but definitely right atrial enlargement and a right ventricular conduction delay, which we'll just call an atypical right bundle branch block, or some sort of splintered QRS complex that we'll call a right ventricular conduction delay. You might see S waves in leads 1 and AVL. We'll see T wave inversion in the precordial leads, and about half of these cases present with signs of a WPW, Wolff-Parkinson-White syndrome. Now, in this Ebstein's patient, we do have that right ventricular conduction delay. We do have signs of right atrial enlargement. You'll see in lead 2 especially, lead 1, lead 2, very large peaked T wave, or P waves, excuse me. And in V1, we see that splintered, and in V2, we can see it as well, V3, V4, this splintered QRS complex. So right bundle branch block type complex, but doesn't quite have those bunny ears. It's a little splintered, and just that right ventricular conduction delay. Also, this patient, we do have that right ventricular conduction delay. See kind of an odd looking right bundle branch block. Doesn't quite have that bunny ear look. Just kind of odd looking, that splintered look. We do have the inverted T waves, as you can see in the precordials. We don't have the signs of right atrial enlargements, but we do have that right ventricular conduction delay along with the T wave inversions. Now let's get into our ventricular tachycardia. So, like we said, not every VTach comes in the same shape, form, or flavor. First, let's talk about right ventricular outflow tachycardia. So this originates from the right ventricular outflow tract, which we'll say connects the right ventricle to the pulmonary artery. So you've got your right ventricle right here. It kind of narrows a little bit going into the pulmonary artery. The left ventricular outflow tract doesn't quite narrow the way the right ventricular tract does. So we just talk about the left ventricle. We don't usually talk about the outflow tract on the left ventricle because it doesn't narrow the way the right ventricular outflow tract does. But this is a tachycardia originating from that right ventricular outflow tract. This is a type of monomorphic VTach that it's an idiopathic VTach, doesn't originate from a structural kind medical cause. So it's most of our idiopathic VTACs originate from the right ventricular outflow tract. So even though the right ventricular outflow tract tachycardia is idiopathic, it doesn't count for a lot of our VTACs that we'll see out in the field. It counts for about 10% of all VTAC. What you'll see on the 12 lead is a left bundle branch block morphology. So the left bundle branch is blocked off. So the VTAC is originating from the right side. Because of this, you also see right axis deviation, and with any of the VTACs, you also see AV dissociation. If you're using your Brugadas criteria or your AVR criteria to distinguish between VTAC and SVT, this 12 lead will fail that Brugada criteria, that AVR criteria, and you'll be left with SVT. The good news is, even though it's a VTAC, it may respond to adenosine. If it doesn't respond to adenosine, it may respond to calcium channel blockers or beta blockers. Long-term therapy considers ablation, but right ventricular outflow tachycardia in that ARVD will not respond to adenosine. So if you're trying adenosine, if you're trying your calcium channel blockers, amiodarone may work. And then long-term therapy for that in the presence of ARVD is going to be an implantable AICD. Here we have a tachycardia that fails Brugada's criteria. We do not have concordance of precordial leads. These are V1, V2, V3 are negatively deflected. V4 is a little isoelectric, and then V5, V6 are positively deflected, so we do have some R-wave progression. But we have a left bundle branch looking complex in V1, and then looking at lead 1, we have a negatively deflected complex, and AVF, we have a positively deflected complex. So we've got right axis deviation, which leads us to think right ventricular outflow tract ventricular tachycardia. Just like we had our right ventricular tachycardias, we can have left ventricular tachycardias. Typically, we'd call them our fascicular VTACs. These are re-entry tachycardias, just originating from our anterior and posterior fascicles in the left ventricle. Typically, you see these in young patients. Again, we're seeing exertional symptoms, chest pain, shortness of breath, diaphoresis on exertion, or in stressful situations. We can also see these in digoxin toxicities. So remember that dig dip that we've talked about before doesn't necessarily indicate a digoxin toxicity. This is one of those things that does indicate digoxin toxicity. For our patients here, they will be responsive to calcium channel blockers, especially verapamil. On our 12 lead, we're going to see definitely AV dissociation, which we're going to see in any of the VTACs. We're also going to see a QRS complex from anywhere from 0.10 to 0.14 seconds. This is a little bit shorter than our typical VTAC complex, which is greater than 0.14 seconds, again, typically. And so it's going to be a little bit shorter, but still going to be wide. You're going to see a right bundle branch block pattern in these patients. You're going to see axis deviation, either right or left axis deviation. And the biggest thing to see are capture beats. It's very easy to misdiagnose this as an SVT with aberrancy. So if you see a capture beat with this patient, that's when you know you have this fascicular VTAC. It can either originate from the posterior or anterior fascicles. Your posterior fascicular VTAC, which is the most common of your fascicular VTACs, it's going to be your right bundle branch pattern with left axis deviation. And then you see an anterior fascicular VTAC, you're going to see a right bundle branch pattern with a right axis deviation. So here's your most common posterior fascicular VTAC. I've got my right bundle branch block pattern. I've got my upright complexes in V1. I've got my slurred S-ways V6 and lead 1. And then I've got my pathologic left axis deviation. Again, this fails Brugada's criteria. So I may misdiagnose this as SVT with aberrancy, but the biggest thing that tells me this is a fascicular VTAC is this capture beat, excuse me. So I'm going along with my VTAC, and then I have this sinus capture beat, and then I go along. So that capture beat is really, really, really critical to your diagnosis of a fascicular VTAC. Now to really throw you for a fun loop, we can have bidirectional VTAC. So our VTAC is alternating its frontal axis, its XY axis. So it goes from beat to beat and alternates its axis 180 degrees. This may also manifest itself in an alternating left bundle branch block pattern and a right bundle branch block pattern. So you look at your bundle branch blocks, it may go from left to right, left to right, left to right, to left to right in every other electrical beat. So please don't confuse this with electrical alternans, which gets bigger and smaller and bigger and smaller. This rotates its axis from one to the other 180 degrees. It's pretty rare, but the causes of bidirectional VTAC more commonly are digoxin toxicity. Again, your dig-dip doesn't distinguish toxicity. Anyone on digoxin can have a dig-dip that's scooped ST segment, but this bidirectional VTAC can be caused by digoxin toxicity. Also, this ingestion of this specific herbal root that is used in Asian naturopathic medicine, usually for fevers, for anxieties. Really just a little bit of ingestion from this herbal root can cause not only respiratory depression, respiratory arrest, sedation, but will lead to this bidirectional ventricular tachycardia. Here's a great example of that, this 12-lead EKG of this patient. We are flipping our axis 180 degrees. If you look at our bundle branch blocks, we're flipping from a left bundle to a right bundle and back and forth and back and forth. Same thing with lead 1. You can see we're flipping from a negative complex to a positive complex to a negative to a positive and back and forth. So we're flipping our axes as well. This is a bidirectional VTAC. Let's move from ventricular tachycardias to a couple indications on 12-lead that you should be activating the cath lab immediately. First is Wellens syndrome. If you see this, this is a critical and emergent stenosis of the left anterior descending coronary artery. If you see this, you should activate the cath lab immediately. What you're going to see is either inverted or biphasic T waves in V2, V3. They may extend a little bit further in precordial leads, but typically V2, V3. You're going to find these ECG findings when your patient is pain-free, which is a little interesting. See that patient's pain-free when chest pain and symptoms, cardiac symptoms appear. These findings will actually disappear. So your patient, if you see this on the 12-lead, you've got these inverted or biphasic T waves and a history of angina with your patient, be thinking Wellens syndrome. Your Wellens syndrome patient, like we said, is going to be either manifesting with biphasic or inverted T waves. Your type A Wellens is going to be your biphasic T waves. Your type B is going to be your inverted T waves. This Wellens syndrome, they're going to progress from type A to type B as they move into an anterior wall MI. So when you see Wellens syndrome signs, these patients are at extremely high risk of having an extensive anterior wall MI within the next couple days to about a week out or so. So the earlier you can catch this, the better prognosis for your patient. For our Wellens syndrome patient here in front of us, we can see, looking at V2, V3, we do have biphasic T waves, initial positive and terminal negative deflections. You can also see it in V1 as well. So if you get this 12-lead on your patient, you see the sign. This is indicative of your Wellens syndrome. We're going to move from this type A Wellens to a type B Wellens syndrome patient. Now you see that the biphasic T waves have disappeared, and they've now turned into just inverted and symmetrical negatively peaked T waves. Now that we've got our type B Wellens syndrome patient, remember we're going to move from type A to type B as they progress, and then it is going to turn into this anterior wall MI. And now we're seeing the Wellens, those Wellens signs turn into anterior wall ST elevation. There are other signs of anterior wall MI that will present without ST elevation on your 12 lead, but you should still be calling a code STEMI, should still be activating the cath lab. So if you see De Winter's T waves, another sign of LAD occlusion on your 12 lead, if you're looking at precordial leads, you're going to see ST depression with this upslope into the T wave, and these T waves are going to be peaked and symmetrical. And if you look at lead AVR, this is one of those instances where we can look at AVR, and AVR can be of some assistance to us. You might see some minimal ST elevation in AVR. So again, we're not seeing any major ST elevation anywhere on our 12 lead. Most of it in the precordial is going to be ST depression, but we're still seeing that upslope, that De Winter's T waves, and we should be calling a code STEMI and activating the cath lab. Here we can see De Winter's T waves. If we look at the precordial leads, we can see both ST depression and these peaked symmetrical T waves, indicative of that LAD occlusion. Also, if we take a peek at AVR, we can see just minimal ST segment elevation. So here, again, we're not seeing any ST elevation in our normal limb leads or precordial leads that would lead us to calling a code STEMI and activating the cath lab. But in this instance, we're seeing these hyperacute T waves that upslope into the peaked T wave, De Winter's T wave, along with AVR ST elevation. So we need to go ahead and activate the cath lab in this instance. Now let's transition to a little bit of critical care and hospital-based interventions. First one we'll talk about is intra-aortic balloon pump. This is a counterpulsation device. This balloon is inserted into a patient's aorta and inflates during diastole. That'll give your patient's failing heart some coronary artery perfusion support. So during diastole, the balloon in the aorta will inflate and push blood into the coronary arteries, providing oxygenation and perfusion to the heart. And then also, on top of that, it's going to decrease afterload, because as it deflates during systole, it's going to create this negative pressure effect, decrease afterload. It's going to kind of suck a little bit of blood into the aorta and to the body through that mechanism. So these patients have failing hearts. They're waiting for some sort of transplant, or perhaps they are pre or post operative, and they're just on this for a little bit of time. But you're going to see this balloon pump in use. You might have to transport it in certain situations. Again, you're not going to encounter this patient in the pre-hospital setting. This is going to be an in-hospital patient 99% of the time. This is the unit you're looking at right here. It's got to be plugged into the patient at all periods of time. The entire unit has to be plugged into the wall. It's got a small battery on board, so basically it can move from the ICU down to your truck and then be plugged in down there as well. It's got a helium tank on board that inflates the balloon. And then that monitor right there will show you the waveforms that you need to see, both balloon inflation, pressure waveform, an EKG waveform, and an arterial line waveform. So if you have to transport these, your truck is going to have a special mount for it and special configuration for it. So our balloon pump monitor on the apparatus is going to display a few things. It's going to display our EKG rhythm like any other EKG monitor would. It's going to display our balloon inflation pressure wave. So here the balloon is inflating, deflating, coming back to stasis, deflated position. And most importantly, it's going to show us our arterial pressure wave. And this is one we really need to pay attention to. So here we have an unassisted beat, and your balloon pump, it can be programmed to inflate with every beat, every other beat, every third beat, so on and so forth, depending on what the cardiologist wants. Here it looks like it's inflating with every other beat. So here we have an unassisted beat before any of it kicks in. We have a normal beat and increases, heart pumps, heart contracts, pushes blood into the coronary arteries. This little notch right here, our dicrotic notch, is our aortic valve closing, going to produce a little back pressure, and that's going to produce this little pressure wave right there with our aortic valve closing. Going to come back down to our diastolic pressure, which is what our heart needs to pump against to push our blood out. And then this assisted beat, heart's going to contract, going to pump, come back up to our pressure here, and then our balloon's going to inflate as it comes into diastole here, right before our dicrotic notch. And come into our diastolic portion here, and our aortic balloon's going to inflate, increase the pressure once more, and this is going to push our blood into our coronary arteries. We're going to have this assisted kind of dicrotic notch-ish plateau right there. And then we're going to come right back down. So as that balloon deflates, again, we're decreasing afterload, and you can see that. So here is our diastolic pressure with the unassisted beat. And that's what our heart has to push against to push blood out into our system. And with balloon deflation, we are decreasing that diastolic pressure, so we're decreasing afterload. So that next unassisted beat, both pressures are decreased. We have a normal dicrotic notch here. We don't have the assisted balloon pump beat right there, but we have this normal waveform, but our pressures are decreased and our heart isn't working quite so hard. The last thing we'll talk about here is a left ventricular assist device, or LVAD, which is a surgically implanted pump that connects your left ventricle to the aorta. So this is for patients with complete heart failure. They're waiting on, it's a bridging device, so they're waiting on heart transplants or other interventions. And we've got this pump that takes blood from the left ventricle using a motor, feeds it through and over to the aorta and out to the body. So we're using this motorized implanted pump plugged into some sort of external battery pack or home-mounted device. So make sure your patients are always plugged into something or have a harness on, and it is working the left ventricle for the patient. These patients, their left ventricle has completely given up and failed, so this pump is working as their left ventricle. Some big things to know about LVAD and LVAD patients. Hopefully they've alerted your 911 center and your EMS agency that they are an LVAD patient in your response area. These patients probably will have no palpable pulses. The newer generation LVADs have this continuous blood flow. They are not. They don't palpate. They don't create palpable pulses because there's no systole, there's no diastole. It's just a continuous flow. The older generation devices do create pulses. Again, this is a bridging device. Patients aren't on these devices for long periods of time. So those older generation devices have gone away, replaced by the newer generations that are continuous. So the first thing to do, and the biggest thing to do, most important thing to do with these patients, is just to assess perfusion status. Is it adequate or is it inadequate? If it's inadequate, we really need to focus on getting the LVAD functioning again. Maybe it's a battery malfunction, it's a battery failure, maybe they need to be plugged into something, maybe a lead has come misplaced, some wiring has come displaced. So we need to focus our efforts on getting the LVAD working again. What cardiologists really advise against is CPR, using that as a last resort in our patients. So if we can't get anything working, can't get anything done, then we can do CPR. So CPR should be kind of a last resort. If we start doing mechanical CPR in these patients, we are bound to displace the device itself, and that's going to lead just to poor outcomes. So we need to leave the device in place, minimize any mechanical CPR on our parts that might displace it, and focus on getting the LVAD up and running again. On our ECG side of things, you put them on the heart monitor. The LVAD should not affect the rhythm that you see on the monitor. They may be in a sinus rhythm, they may be in an AFib, a flutter, they may be in a ventricular rhythm, might be in a junctional rhythm. The LVAD itself is not going to affect the ECG rhythm. But if the rhythm is affecting right ventricular output, we need to do something about it. So the only time we're going to treat the rhythm on the monitor, and again we're treating the patient, not the monitor, but the only time we're treating the rhythm if it's affecting right ventricular output, which is going to affect left atrial filling and left ventricular filling and the pump itself. So again, going back to the previous slide, we're going to assess perfusion status first. If they're not perfusing adequately, we need to do something about it. If they are perfusing adequately, and we see a ventricular rhythm in let's say an AIVR rhythm on the monitor, but they're perfusing fine, then we don't need to treat the rhythm. We just need to treat the patient and make sure they're perfusing first and foremost. So that's the XYZs of 12-lead analysis. Again, you've been through the ABCs ad nauseum. You know the ins and outs, you know the mundane stuff of 12-lead. Hopefully this was a bit interesting to you, and hopefully you go through it at least once or twice a year. I know I do, just to keep myself up to date. And like we said at the outset of this, hopefully save a couple patients and improve the outcomes of another patients by catching a few things that we might otherwise miss. So if you have any questions, please let us know.